thank you all for coming out, I guess, this evening and taking part in the beginning of, I guess, of Movember. I think I was preluded by one of my colleagues who gave a little information about sort of the movement and what's been going on in the last few years, and how I think Canada has been, I think, made proud by the last year being, I guess, the #1 country to have raised so much funds for prostate cancer survivorship, research, you name it. So what I'd like to do today, and I just thought since I graduated here in 1993, and I've been pretty impressed at how things have changed here, and even being in this auditorium, and it's quite impressive. So just as sort of something to give back to the community, as well to help out other men. So I think part of the issue, and I think what Movember is all about, is just education, letting people know about things. And in my practice, a lot of dealing with prostate problems is sort of fear and lack of knowledge. So hopefully I'll be able to share some insight on what I think are the basics for understanding basics of prostate health, management of male health issues, and with regards to treatments of the common things of enlarged prostate and prostate cancer. So hopefully share some insight on that. I'm not really sure, maybe we'll save questions to the end, or if you guys want to have a big question you want to ask me during the way, so I'm kind of open to both. What I wanted to do first, really, just to sort of take us through a basic of the anatomy of the prostate, what its real reasons for, what are the functions, and some of the age-related changes that occur to this special organ over time. Mainly enlargement of the prostate, association with erectile dysfunction, and most important that we all sort of fear and consider is prostate cancer. So, in short, anyone with Y chromosome for male will have a certain part of the genital tract dedicated to becoming a prostate. And this is usually in an adolescent, something smaller than a walnut-sized organ. It sits around the urethra, and its main function is during puberty to get a little bit bigger and to donate toward the material for reproduction. So when a male orgasms, there's about 80% of the material actually come from little bunny ears structures that are sitting behind the prostate called the seminal vesicles. About 15% of the fluids come from the prostate. It actually secretes an alkaline material against the, to match out the acidic environment of the vaginal area for reproduction. So that's really one of the main functions is for reproduction. It also creates a very special serine protease, a protein that helps liquefy the ejaculate within about 30 minutes of ejaculation. That protein's called PSA. So when you're all scratching your heads, well, what is PSA? That's what really PSA is meant to be done, to be used for. It's actually in the ejaculate a very high quantity. Some of it actually goes into our blood, and that's what we can measure, and we'll talk about that a little later on. So just some basics of the anatomy, what the roles are, and what we will expect. So the prostate, unfortunately, it's not like an apple where you can take a bite and anywhere along the prostate it'll be the same material. There's actually 3 different zones. So you can see above, you can see the bladder, and that's what funnels down, and the tube passes for urination. There's also that little duct, and you can see heading into the top left corner toward the seminal vesicle, which also joins, as I mentioned, with reproduction. Now, look closely at the blue zone. You'll see what's called the peripheral zone. That's at the backside of the prostate. That's where prostate cancer in about 80% of men occur. So that's why rectal examinations are important, because you can feel that zone quite well. And if you look at the green zone, that's the zone. So it's 2 different zones that have 2 different pathologies. This is the one why it's called transition zone, because once you get 40 and 50, there are certain hormonal changes that zone will continue to grow. That's where enlarged prostate occurs. And if you look at it, that's what circumscribes the urethra and kind of chokes off and can give urinary symptoms. So those are some of the basic anatomy things that you should think about when dealing with the prostate. It's not a one whole structure. So on the left, we can see sort of a younger individual who can urinate freely without much obstruction. And on the right, we can see that prostate sometimes double, tripling in size. So, when we talk about prostate sizes, we're thinking usually 30 to 50 grams. So kind of like the size of a tangerine. That's kind of a small prostate. Men in their 50s, 60s can sometimes get up to an apple size, what I consider 50 to 80 grams. There's also some men who I've seen with 300-gram prostates, the size of a grapefruit. So these are all potential growth rates of prostates. But just because it's a large prostate doesn't necessarily mean it's going to block up that channel. That's the most important in terms of what creates symptoms for men, is not just how big it is, but how compressed that central urethra, the tube, is because of this enlarged prostate. What about BPH incidence? Is this something that we're all going to get? Yes. I think if all men live to 100 or 120, we would not, at some point, not urinate. Why does this occur? Well, we all have testosterone as males, and that testosterone can be converted to another subtype called DHT, dihydroxytestosterone. And that does two things. It enlarges your prostate, and it also leads to male pattern baldness. How many people here have heard of Propecia? So what is Propecia? It's the same thing as Proscar. Has everyone heard of Proscar or Avodart? So those are medications to shrink the prostate. So what Pfizer has done, or Merck has done, they've decided, well, we can shrink the prostate, but if we give less, instead of giving 5 milligrams, we'll give 1 milligram, we can sell it as Propecia. It does the same thing. It works by the same enzymatic pathway to reduce DHT and help with male pattern baldness. But ultimately, the DHT increases. You can see the incidence starts going up in the 40s and 50s. So almost per decade, going up 10%, starting at 50. So about 40–50% of men at 50 already have signs of BPH, benign, so not cancer, prostatic hyperplasia. And looking back at the other slide, that's the transition zone that's gotten a little bit bigger. So, and if we all, men in their 70s and 80s, unfortunately, they all have some of the following questionnaire symptoms. So this is something that you guys can all Google at home if you want, or look up. It's called the IPSS. It stands for the International Prostate Symptom Score. It's been translated in about 20 different languages and has been sort of the gold standard. It's very simple to fill out. It's 7 questions, each with a value ranging, maybe too small to see here, but starting at the top one, the sense of incomplete emptying. So you get guys who pee and, I could have probably emptied a bit more, and I kind of feel like there's some left over. And you kind of grade it from 1 to 5. Next one, frequency. Sometimes some men are peeing every 2 hours or less. This could be BPH or could be some other things as well, but it's something else that's picked up on the questionnaire. Intermittency. Some guys who are peeing and they're kind of slow, stop, stows. They're staccadic in their urinating pattern. You also have urgency. Sometimes men, when they gotta go, they have to run to the bathroom. So these are other potential signs of BPH or other bladder problems. Weak stream, that's kind of one of the first things that men start noticing, but I think that's just with age and I'll be okay. So those are usually the underlying first thing that start 40s and 50s and pick up. Straining, that's kind of usually a late finding. You gotta sit there and push a little harder. The nocturia, that's kind of the one that I think brings most people to the doctor, because all of a sudden it starts interfering with your sleep habits. You're waking up 2 times a night to pee. So that's what sort of triggers, I think, the initial response maybe to going to your family doctor or going to see a specialist. And the final one, which at least helps me understand the severity, is just the quality of life assessment, which is really a simple question. If you had to live like this the rest of your life, would you be happy or unhappy? And based on that and the current treatment, so we can administer this simple questionnaire during the initial visit and following up, which will help direct treatment. So it's a non-invasive tool. So what about PSA? And I know I kind of mentioned about it, and I think everyone here, I guess by show of hands, because most of you guys are young or potential PSA people. Has anyone here had their PSA checked? So I guess I don't have to mention the word. The usual cutoff when you go to your lab and you look at the result, it's going to have like less than 4 or 4 and above. And if it's 4.1, it'll be flagged as high. So, and I'm sure if you haven't touched a newspaper in a little while or turned on the news, you'll see a lot of controversy about PSA, especially in the last year. Some studies saying that maybe it's not the best tool. We're not, in looking at a population scale, we're not potentially saving lives. And it reminds me of what happened about 4 or 5 years ago with mammography, where it was almost downgraded because we weren't on a population scale doing a survival benefit. And I think what's happened in the States now with the US task force, they've actually downgraded it. So some family physician people aren't even doing it as part of insurance programs. And I think that's, to me, 5 and 10 years, we're going to see the impact of that. But it's a controversial topic, and I guess I'll try and sum it up and make it, edible in small pieces, because I'm going to give you a lot of information tonight. The basics are, when you look at the cutoff, it's 4 and above, are considered abnormal, less than 4 abnormal. However, we have to remember that with age, I mentioned the prostate gets larger. So what's making PSA? It's prostate tissue, good, healthy tissue. So if you have a very big prostate, your PSA will go up. And sometimes we can accept it going up 0.75 a year. So the guy's coming in whose PSA is 2 and jumps up to 3.5, even though it's not 4, it may trigger us to watch them a little closely rather than doing a PSA every year. So the baseline is that we recommend anyone over the age of 50 who doesn't have a family relative like a father or brother that has prostate cancer to have a DRE, a digital rectal exam, and a PSA test yearly. If you do have a family first-line relative, not like your uncles, brothers, or someone you know, it has to be a first-line relative, then we would recommend getting a PSA before either 40 to 45 with a rectal exam. What you can see here is basically that evolution. So as you can see, every age group, you're going to see a rise in PSA. And that will also increase depending on the size of the prostate. The truth be told that even though someone does check your prostate with their finger, it's kind of like feeling the back of your hand. How big's my hand? Well, I can only feel the back of it. I'm really feeling that posterior zone. You really can't assess the full gland. So there are many times in practice where I see people whose PSAs are 6. Well, I may just send them for a quick ultrasound and they come back with a 100-gram prostate. And I kind of reassure them saying, well, that just makes sense. Versus the person who comes in who's got a 30-gram prostate and their PSA 6, then we're a little bit more concerned. Does that make sense? So there is some variability. There's not sort of a magic number that if-then pathway. We always like to look at that in context with the urinary symptoms, the size of the prostate, and the rectal exam. So a lot of things to mention here. So if someone comes in and they're 75 years old, their PSA is 4.1, I'm not as concerned versus the guy who's 47. So there's a lot of variability there. Going back to what we talked about, going into BPH, enlarged prostate, it's usually the first thing that people bring is a first complaint. They don't come to see me unless they've already had a workup and have cancer. No one sort of walks in and says, look, I think I have prostate cancer. It's usually asymptomatic. This is what kind of brings people in through the front door, and I've got some urinary symptoms, get checked out. For the very early urinary symptoms, going back to BPH now, treatments would usually be either watchful waiting. We'll see you and check on people either every 6 months or 12 months with a PSA, and other questionnaires, to starting them on a medication that relaxes the prostate. So has anyone here heard of Flomax or Zatrol or Rapaflo? So these are all what's considered alpha blockers. So the prostate's pretty unique in that we actually have smooth muscle. So unlike your skeletal muscle, this is smooth muscle which is under a certain tone. And that smooth muscle, because the prostate's made up of about 50% of that. Again, why muscle? Because it's got to contract and expulse this material for reproduction. So initially, there was some non-selective ones. I don't know if people in the room have ever tried Cardura, or there's a Hytrin. These are kind of older, non-selective. And they would work. People would help their urinary symptoms. However, it wasn't specific to the smooth muscle in the prostate. So some people would get dizzy, stuffy nose, and other kind of side effects. It works quite quickly. That's the nice thing about it. So when we start men on this, they've got some urinary symptoms. Within a week or so, they start noticing some improvements. And again, it helps simply relax the muscle, and it works quite specific to the prostate. As I mentioned, those are the first two, which really no one writes this anymore. Unfortunately, there are certain provinces where they're actually still writing this. So British Columbia, Calgary, and Alberta, just by their health programs and cost issues. Fortunately, Quebec, we are kind of leaders in adoption. We're the first to accept Rapaflo, which has been out for a month and covered by the RAMQ now, which is a drug which has been introduced in the States since 2006. Probably the most selective and the most safe medication for BPH. So for those who are on things or are having some symptoms of stuffy nose, headaches, and so forth, dizziness, it's something to consider as part of your BPH algorithm. So alpha-1 receptors, as you can see on the left, that's what we're trying to hit. We want the 1A, which works in the prostate, the urethra. Also for kidney stones. So whoever's, show of hands, anyone had a kidney stone before? Some people, hands in the back. So you may remember, hey, the guy wrote me for Flomax. That's for BPH. Why is that? Well, the lower ureter also has that, those kind of receptors. So if we can relax those, it will help with pain, earlier passage of the stone. So even women, so if some woman ever has a kidney stone and they're writing for Flomax, and the pharmacist, well, this is for prostate, That's why. We're trying to relax that to allow